for our breast cancer risk by reducing high-risk behavior. I'm troubled because it sounds easy, but it can be hard. You know, it can really be hard for people to achieve, for women and men both, to achieve their goals. And in order to look at risk reduction in a holistic way, we have to look at the differences, disparities, and discrimination in cancer prevention and treatment that, you know, need to be addressed before we can move forward across the United States. And cancer health equity is, you know, it doesn't have to be a dream. It's something that we can keep on plugging forward and believing in, but that takes an organized individual and community and corporate effort to make sure that when we talk about risk reduction, that we're talking to all people. Genetics, and then there's some other things that may interfere with how easy it sounds. Some of those things would be skin color, genetics, socioeconomics, inherited genes, environmental exposures, zip code. There's a poster out front about the Sister Pack, and that particular project identified 7 zip codes in the city of Milwaukee where Black women die 2 times more than any other area in Milwaukee County. And so that zip code can determine your health. You know, it's kind of unfathomable, but it's true. And so these disparities, you know, we do have to look at them and shake them up and try to figure out how to circumvent, to go around them, to take them away, to remove them. On the front end, and I consider this continuum, cancer care to be a continuum, and so over here is prevention, and over here is treatment. So on the front end in prevention, you know, where is the dollar amount and the attention? Okay, because a lot is on the rear end. And we all know that this is Breast Cancer Awareness Month, and what is the messaging? Have you had yours? Have you had your screening? And to prompt, you know, your sister, your mother, your friend, your cousin, your daughter to get theirs. And so equity in the continuum of care, when we know that prevention can prevent and reduce 1 in 8 to 1 in 3, you know, where is this shift and when will it start? You know, that as a global effort that we start preaching prevention versus finding and treating. When we start educating about the impact of lifestyle choices on breast cancer risk, it's not one size, one type, one easy behavioral modification fits all. And for you all, you have to think about what your limitations, restraints, and barriers might be. You know, I just spoke to community and other types of barriers, but we all as individuals have barriers too, you know, that we need to take into account. Your resources, your willpower, your long-range thinking and execution of goals will determine your success. And as an educator, I used to talk about WIIFM. To motivate students, they had to really know what was in it for them. And then, you know, with that being what they, not just the content, but they wanted to know how it would benefit them. You know, that once that was communicated, they seemed to want to learn and do more. Now, this is kind of busy, but I just want you to take a look at the top 3. The top 3 are Louisiana, Wisconsin, and Mississippi. So again, When we talk about prevention, we're swimming upstream in Wisconsin. Okay, these are state rates. So not just those 7 zip codes in Milwaukee have complex breast cancer rates that are extraordinary, but rural Wisconsin areas do as well. You know, so we have to look at that and try to figure out what can be done in those areas across the state for prevention. What can we teach that can be applicable to every type of disparity that may exist? Decisions have to be made, and perhaps more funding can be given to develop a curriculum that's like a K-3 to 12 type that's presented globally but adapted for environmental changes, locational changes, because this recipe, the evidence-based lifestyle changes that reduce cancer, you know, we've heard that over and over. But how do we apply it so that people can internalize it and make it a long-term lifestyle practice? You have to love yourself enough, too, to value, create, and live a healthy lifestyle. And so there are many benefits, but, you know, they're not attainable if you don't. Love is the cure. Sisters for Cure, we're not looking for a treatment that's, you know, tied into surgery or a chemo or a radiation. We're looking for people to love themselves more and to teach that as a life skill. Our health is our wealth. Our health is our wealth. And in order to maintain our health, you have to recognize up front that you need family, friend, and personal support, you know, to make it a long-term, lasting effort that can be intergenerational and cultivated and adapted and changed over time so that it's sustainable. And in doing that, you know, with my grandbaby, this is actually my daughter's, one of her favorite movies. And so I heard this so many times, just keep swimming, swimming, swimming. And it's my life model. You know, I carry in my car, I still have it. It's kind of icky now, but a stress ball, a Dory stress ball. And it's in the compartment in the door, and so I can be humming along, just keep swimming, swimming, swimming. And that's what we all have to do. You know, we just have to really just tackle it, jump in, and keep swimming. Just a thought for you to take a look at stress and the connection between cancer and inflammation. There's more information that's going to come out about that. And so, you know, look at even the proliferation about curcumin and different spices, okay, that's you know, marketable right now and seems to be researchable evidence. I want you to know that these are good resources. The American Cancer Society guidelines, you can look those up. There's a wealth of information. And then the other one that I just want to point out is the American Institute for Cancer Research. There's a wealth of information in on those 2 websites. And then it's been my privilege to be here and to speak with you. And I hope that I said something that makes a difference. And thank you for your attention.
So much. Why is it that we think it as women, I think we think it's selfish to take care of ourselves instead of smart. We put ourselves last too often. All right, remember your cards on your table. We have folks coming around that'll pick up your question cards, so jot those down as we go. Thank you so much. I love Dory. It's kind of my life motto, too, during those times when you really are just swimming through the chaos of it all. Our second panelist is Joanne Becker, a board-certified genetics counselor at the UW Carbone Cancer Center. Joanne attended Marietta College in Ohio and graduate school here at the UW. She's been providing genetic counseling at the University of Wisconsin throughout her entire career. For 20 years, she's been working in oncology genetics, helping patients with breast and other types of cancer to understand how genetics play a factor in that. Please help me welcome Joanne Becker to the stage. Thank you, Joanne.
I'm on. Thing just fell off my belt, so hang on.
Talk among yourselves.
Okay. First of all, thank you. Thank
There
you
you
to
go.
Tommy and Sue Ann for inviting me and the whole organization group. I'm very pleased to be here, and it's nice to see some familiar faces in the audience, so that's always nice as well. So I'm going to start by telling you that cancer is common, as you probably are very well aware, and I just have to figure out which end of this is the right one to point, so bear with me. Not that one, not that one. Okay. Hang on. Is this which one changes? Yeah, okay. Thank you. So cancer is common. Just about every family has some cancer in it. Cancer is also genetic, and what I mean by that is in order for a healthy cell to become a cancerous cell, there has to be changes in the genes. And these are usually changes that happen over the course of a lifetime, not just because we don't live in isolation in a closed up box, we live. But in a small percentage of families, individuals can be born with one particular gene that's not working right, that's a cancer susceptibility or cancer predisposing gene, that puts that individual or individuals in that family at higher risk of getting certain cancers. Not all cancers across the board, but certain specific cancers. And we think that about 5 to 10% of most cancers are in fact due to a cancer risk gene. Most families where breast cancer has occurred, there's only one woman in the family with breast cancer. Are you seeing anything on? No? There you go. Most families, there's only one person in the family with breast cancer. In about a quarter of families where breast cancer has occurred, there are 2 or more affected individuals. But overlapping into both of those categories, there are families where there is this inherited susceptibility to breast cancer or an inherited susceptibility to breast and ovarian cancer. And again, about 5 to 10%. So that's the small group, that small wedge, the blue wedge of that pie chart, if you will. And we know that about a quarter of families where breast cancer has occurred either in the particular individual or in combination with their family history, there's a reason to talk about, could there be an inherited susceptibility to breast cancer in our family? About a quarter of the time, there's a reason for the discussion. Now, I'm going to guess that most of you have probably heard about the BRCA1 and BRCA2 genes that are associated with what we call hereditary breast and ovarian cancer syndrome. So these are families where we sometimes just see breast cancer, families where we sometimes just see ovarian cancer, and families where we see a combination of both breast and ovarian cancer. But there are other genes out there as well. There's no question at all, BRCA1 and BRCA2 are the first 2 genes that I think of when I see a young woman with breast cancer or a family history of breast cancer. I call them major players because they do account for a good chunk of that blue wedge that I showed you in that previous slide. But we know of other breast cancer genes that are either high-risk breast cancer genes or moderate-risk breast cancer genes, and I'll define moderate-risk breast cancer genes for you as ones where the chance of getting breast cancer associated with that particular genetic message is 2 times higher than the average woman's risk. Sometimes it's as high as 3 or 4 times the average woman's risk. So that's a moderate risk breast cancer genes. And we certainly know of several other breast cancer genes that we're aware of that we can test for and can impact a family. There are also newer breast cancer genes that we're learning about that can play an important role in families as well. There will be other breast cancer genes that we are going to discover that we don't know about right now. There are many a family that I've seen over the years where it looks like there's gotta be a gene related to an inherited susceptibility to cancer in that particular family. And yet we do our tests and we don't find anything. And it can be very frustrating, obviously, for all involved. But, you know, it doesn't mean there isn't a stronger genetic factor. It's just we're not smart enough yet. We haven't figured it out. But I think with all the research and work that's being done, there's hope that we will figure it out more in more families. So part of what my job is to evaluate a person's personal history, their family history, to figure out, is this one of these situations where we think there's a stronger genetic factor playing a role, where a person may have been born with a genetic message from conception that put them at higher risk of getting breast cancer or some other combination of cancers. And what I do is I ask a lot of questions, kind of playing detective. I'm asking questions that basically fall into 3 groups. I'm looking at age at diagnosis of cancers in families, usually looking for younger than average age onset, so certainly breast cancer under the age of 50 is considered young age of onset breast cancer. I'm looking for, are there any rare cancers or less common cancers? For example, male breast cancer. For example, childhood cancers or sarcomas or some other types of cancer that are not as common. What are we seeing there? And what about the whole picture? What cancers have occurred in the family? Does that particular combination of cancers make me suspect a particular gene or genes that might be related to inherited susceptibility to cancer? So this long list that's on the slide I call the clues or the red flags, and I'm not going to read them all to you, but they basically all will fall into those 3 categories that I just mentioned. Young age breast cancer, breast and ovarian cancer in a family, male breast cancer, anyone that's had more than one primary cancer themselves, whether it's 2 breast cancers, not recurrence, but 2 separate primary breast cancers, in either the same breast or in the opposite breast, or just a combination of the cancers that have occurred in the family. And when we do suspect that there might be an inherited susceptibility in that family, we can offer testing. And testing is a process that begins by genetic counseling, and obviously I'm biased. I think genetic counseling should always precede any genetic testing. But what we're doing is looking at the family history, trying to figure out, is this a family where testing might find a mutation, an alteration in a gene that could be related to cancer risk? We talk about what the outcomes could be from this test. What are the possible results? And what are we going to do about it? If we find a change, what do we have to offer? So ideally, testing begins with evaluating a person or an individual in the family who has had cancer themselves, rather than starting with the healthy sister or daughter. If very frequently I'll see women who come in because they have a close relative who had breast cancer. And my first question is your relative still living? And if they are, and if we're thinking about doing genetic testing, I would prefer to first test that individual to see if we can identify a mutation in the gene, rather than start with the healthy, unaffected person. Now, sometimes that isn't an option, obviously. And there are interpretation of results that need to be clarified up front before we do testing of a healthy, unaffected individual, okay? So what has changed in the last few years has been our ability to offer what we call panel testing. And panel testing just means that we can look at a whole bunch of genes at the same time. Now, in the past, let's say we did BRCA1 and BRCA2 testing, and for a woman who had breast cancer at age 28, let's say. And we would start with BRCA1 and 2, and then if we didn't find anything, we would say, well, this could also be related to, and I would come up with the name of another gene. And then we would look at that gene and see if we found anything. Well, now we can look at those genes at the same time. Or we can look at a whole group of breast cancer genes at the same time. Or we can look at breast and ovarian cancer genes. Or in a family that might have lots of different cancers in it, we can look at a panel of genes that crosses over breast cancer genes, let's say colon cancer genes, pancreatic cancer genes. So it gives us an ability to see more cost effective as well. We know that if we do testing big panels, there's a chance we might find a variation in a gene that we may not know at this moment in time whether that change is related to cancer risk or if it's a normal variation. And that happens whenever you do any genetic testing, but as we do bigger panels, the likelihood that we might find a variation that we can't exactly interpret today, that increases. So I want to show you a slide. Hang on here. There we go. And I don't want you to focus on which genes exactly. I want you to focus on what it's showing on the left side. If we this is from data compiled from about 28,000 panel tests at one particular lab that looked at 25 genes in their panel test. And for individuals who had breast cancer, most of which were women, there were some men with breast cancer, and about half of those people tested had a mutation in the BRCA1 or 2 gene. But the other half of the circle are families where a mutation was identified either in a different breast cancer gene, which is that light blue, light pinks, or the very light blue section, high and moderate breast cancer genes, but there were also some mutations found in genes that you wouldn't necessarily think first about breast cancer. For example, there are some colon cancer genes there where a mutation has been found in a person with breast cancer. And we think for some of the colon cancer genes, breast cancer can be part of the spectrum there. So again, I don't want you to focus on all the which genes exactly, but just that whole idea. So what are the benefits and limitations? Well, of testing, it allows us to figure out, first of all, is there an inherited susceptibility to cancer in that family? And if we can figure that out, who is at increased risk, who isn't at increased risk, and then what do we do about that? The limitations, most mutations in the testing labs are findable. Most are findable, but we know that there still are some mutations that may be there that technically we just can't find. What I was referring to previously with regard to testing a healthy unaffected relative is if we know a mutation in a particular gene's already been found in their mother, their sister, their aunt, or whoever it may be, and then we test that healthy person, we get a clear answer. Either they have it or they don't. But if we start with testing that healthy person and we don't know if there's a mutation that's actually related to the cancers in that family, a negative result doesn't mean that person's risk is the same as the average risk. It's still based on family history. So what do we have to offer when comes down to, do we start screening earlier? What tools do we use for breast? Let's focus on breast cancer at this moment. Well, when do we start screening? Do we wait till age 40 or 50 for the first mammogram? No, absolutely not in families where there's an inherited susceptibility. What about medication to reduce risk, such as tamoxifen, many of you have probably heard about. And we do discuss the option of prophylactic or risk-reducing surgery. Bilateral mastectomy is the most aggressive approach, but it significantly reduces the risk. It is not the option that all women choose. There is no mandatory, if you have a gene mutation related to breast cancer, you have to have a bilateral mastectomy. No, it is obviously always, or it should be obvious, it's always a personal choice with a lot of thinking that goes behind it. So again, why is this important? Well, it's to figure out who's at risk and what can we do about that to either identify cancer at an earlier stage or reduce the risk. And what about figuring out who isn't, who may think they're at increased risk, but can learn that they're not at increased risk. They don't need the high-risk screening. And that's equally important. Some people are worried about insurance and health insurance, and obviously that's something important to be worried about. But I will say there are laws that exist, both federal and state laws, that address genetic information and health insurance that can or basically prevent discrimination based on your genetic information, so that's good. There are laws related to employer-employee relationships and genetic information. And I want to finish off by telling you, and I think everyone should be aware that there is something called DNA banking. Let's say the person in the family I would like to test first, says, I don't want to do it. There's no way. I'm just not going to do that testing. In that situation, we can say, hey, that's fine. That's a personal choice. You do not need to test. But would you consider DNA banking? Consider, usually from a blood sample, we can get some genetic material, DNA, that can be stored away, and it costs about $100 to store a sample for at least 20 years, so that what if down the road the person we want to test is no longer living and their family is going, you know what, Mom stored some of her DNA and we'd like to use a portion of that for genetic testing. Or for the person who had testing and we came up with a negative result. We didn't find anything, and yet this family is concerning, or that person's personal history is concerning. It's like, I don't know what we're going to learn 5 years from now or 10 years from now, but if there's some of that genetic material, we could say, hey, we could use a portion of that for more testing. Or if that person is no longer living and the family says, hey, they tested for BRCA1 and 2, but we never looked at any of these other new genes that you're talking about, we could use a portion of that sample. So the cost that I'm referring to, that $100-ish, is for storing the sample. It's like a safety deposit box. Nobody touches it, it's just there, it's in a lab. There are still the fees associated with testing. And lastly, I think we've all heard the phrase, knowledge is powerful. I definitely believe that learning about one's genetic risk can save lives in families. I think it's a gift to families. I've heard that from patients as well. You know, this is what I'm giving to my family by taking this test, and I don't know what we're going to learn, but if we find something, I don't think of it as a bad thing, as pointing fingers of blame. It came from Mom's side. No, it came from Dad's side. No, let's use this information to be helpful, to figure out who's at increased risk, who isn't at increased risk, and what can we do to reduce those risks. So thank you all very, very much, and be happy to answer questions later. Thank you.
Thank you. Good job.
Thank you.
We're all set. Has this been bugging you guys? It's been bugging me. That was probably on my shoe. That was toilet paper. Okay. Thank you so much. Question cards, they're coming around to pick those up. If you've been jotting down questions, keep at it. You're doing a great job. Our third panelist next is Dr. Mai Elazabi, an assistant professor of radiology in the breast imaging section at the University of Wisconsin School of Medicine and Public Health. She received her medical degree from Cairo University Faculty of Medicine in Cairo, Egypt, where she also completed a diagnostic radiology residency and earned her MS degree in radiology. After joining the University of Wisconsin, Dr. Elazabi completed a radiology residency as well as fellowship training in breast imaging. She currently is the Director for Resident and Medical Student Education in the Breast Imaging Section and an Assistant Program Director for the Radiology Residency. Dr. Elizabi focuses on the promotion of screening and diagnosis of breast cancer regionally, nationally, and internationally through promotion of breast imaging education and quality improvement processes. Please welcome Dr. Elizabi.
Way down. Thank you, Pam, for the introduction. Good morning, everybody. I just want to start out by thanking the Wisconsin Women's Health Foundation and the Thompson family for inviting me to this wonderful event. And more.
Good. So you're going to need to use the podium.
Oh, okay.
Just turn it here to the side so we can see you.
So I can. Yes. I was so happy in the morning. I was like, I don't have to stand behind the podium. I'd like to thank everybody. I'd like to thank the Thompson family for inviting me for this wonderful event and for all their great work for promoting women's health in our state. I'd just like to start out by saying screening mammography or screening for breast cancer is a huge topic. We won't be able to cover it in 10 minutes, but I wanted to give you a few highlights about what screening means, what it entails, and how can we as healthcare consumers, as patients, learn our rights, learn some of the facts that will help us make informed decisions moving forward. So in the last few years, there's been a lot of contradicting information about the value of screening. And that contradicting information has not only been presented in the media, but it's also been available in the medical literature as well. And I would say that there are two sides to the story. There are very valid arguments from both sides. The problem is that when this information is presented to the public, there is not a lot of transparency in the information. Which information we're dealing with and what does it mean and entail when it impacts individual patients. When we look at the data that's out there and that applies to healthcare information in general, there are two pictures to it, two sides. The population health perspective, and that's dealing with big numbers, and the individual perspective, what's happening to me as a patient. The population data, it can be global information about the natural history of disease, how it's being treated, what are the benefits, what are the most beneficial treatment options. It can be across the country or our state, for example. However, the individual perspective is a little bit different. It does utilize some of that information that we have about the natural history of disease, but it also takes into account the patient's individual health concerns, their beliefs, their perceptions, a lot of surrounding circumstances like some of the social factors as well. And that does impact their personal decisions about how they take care of themselves and how they choose to deal with healthcare services. The big picture, the population numbers, and we've heard about the breast cancer. It is the most common cancer in women. In 2016 or 2017, the estimates for breast cancer are around 260,000 women across the country diagnosed with breast cancer. Unfortunately, around 40,000 would have lost their lives to breast cancer. When we look in Wisconsin, our numbers, again, and speaking to Phyllis's point, we do have larger numbers in Wisconsin, around 4,000 per year diagnosed with breast cancer and 700 fatalities due to breast cancer. Some other facts, we know that about 1 in 8 women will be diagnosed with breast cancer during their lifetime. Again, that's more of the average risk. 3/4 of breast cancer occur in women without a family history of breast cancer. And again, that speaks to Joanne's point, is that we still don't know everything about the genetics of breast cancer, how it happens, how does the damage to our DNA occur, and there's a lot more for us to learn. And I would like to emphasize, I think this, I apologize, it's a little bit small, but the majority of breast cancers occur in patients from the age of 45 to the age of 75. And keep that number in mind, because that's an important number when we look at some of the guidelines for recommendations for when to start screening and how often to start screening. I would say that 1/6 of breast cancer occur in patients in their 40s. Again, that's a very important number. 1 in 6 breast cancers occur in younger patients. Think of that as we think of what are the available societal guidelines currently. We know from, again, many years of data, we've been collecting breast cancer information for many decades. Screening mammography or screening for breast cancer has been available for approximately 40 years. Looking at this data, we know that if we identify cancers at an earlier age, earlier size, and that's typically about 1 to 2 centimeters, we get better results. We get better results as far as treatment options. We get better results as far as our prognosis. And that really emphasizes the value of screening. Can we identify a way to find these cancers earlier? And that's where mammography helps us. It identifies cancers before they are felt, before they are physically felt by the clinician or by the patient. We know from breast cancer research as well, and looking at the data, that approximately 40% of reduction in breast cancer mortality occurred in the US between 1990 and 2016. That's a significant number. When we look at that, these are many women who have gained lives just because they got the screening test, identifying the cancers early. It also reflects the improvements in treatment. The treatment options currently that we have significantly improved our outcome and morbidity. I apologize, it seems like this presentation is going on its own. But I think I would say that the 40%, I would emphasize, the 40% reduction in breast cancer mortality has been by starting screening at 40 and going every year. The old recommendations that we've had and we've heard of repeatedly. What happens with a screening? A patient comes in, we get the images, radiologist reviews the mammogram, and the patient receives results, general results by the mail, saying your screening mammogram is fine, you don't need to come back for any additional imaging, and we'll see you in a year. The primary care provider gets the more detailed information, the more medical terms. And this is an example of a screening mammogram. This is a breast cancer survival. She had prior history of left breast cancer, treated with lumpectomy and radiation. Her screening mammogram was negative, and we told her, we're happy, you get a green check mark, and we will see you next year. This is another patient who's also a breast cancer survival who had a finding in her right breast mammogram or images. In this case, the patient will receive a letter saying, can you come back to clinic? We see a change in your mammogram, and we need to investigate that further. The patient receives a letter in the mail, very general terms, and the primary care provider gets a notification of the details of what we are seeing. And we'll get back to our patient in a little bit. So if breast cancer screening has been doing so well, where is the confusion? Why do we get all these contradicting recommendations from the medical community? We know that mammography, which is our primary tool for screening breast cancer, it's not perfect. Nothing is perfect in life. But we know it has been doing a lot of good over the many years that we have tested it. What are some of the concerns or some of the shortcomings of mammography? Radiation, it definitely is. It's an X-ray tool. But when we look at the radiation, it's minimal amount of radiation. It's similar to living in Denver. So minimal amounts of radiation. It is not 100% fail-proof. We know that mammograms can miss cancer. This is a fact that we know. The percentage of missed cancers, however, it's a smaller percentage than is, again, portrayed. Some of the reasons the mammograms fail to identify cancer may be related to the type of cancer, or maybe related to the patient's breast tissue density. Just like how we are different on the outside, we're different on the inside as well. The composition of our breast tissue is different from one patient to the other. The denser the breast tissue, the harder the mammogram. Anxiety, when we're called back for tests, there is a significant anxiety. However, it's transient, and if we know ahead of time what to expect from that test, our anxiety has been shown to be less. There are additional imaging occasionally when patients when we identify abnormalities on their imaging, where they're going to come back for additional imaging. A small percentage are going to have a biopsy before we can tell them your images are fine. And this is an example of what is the proportion of patients coming back. If we're seeing 100 patients, only 2 patients might come back for a biopsy. 2 patients might be seen in 6 months, again, to confirm that these findings are benign. So it's not a huge percentage as it is portrayed occasionally. So going back to our patient, our breast cancer survivor, she came back for additional imaging, and on ultrasound, this looked like a benign finding, a benign cyst. And again, once we've confirmed what the process is going on with her mammogram, she can go back to the routine surveillance that she is following. I would emphasize the overdiagnosis. This is something that has been brought up consistently, again, in the discussions and debates against screening. Overdiagnosis refers to a term when we think that some breast cancers are not going to progress to the extent of affecting one's health or affecting one's life. This is definitely through looking at the literature, looking at many, many years of following patients with breast cancer. But really, it pertains to a very small subset of cancers, which are the DCIS, ductal carcinoma in situ. These types of cancers, and even not all of them, a small proportion of them, might not progress as rapidly as other types of cancer. The percentage of these cancers, they are very low percentage, I would say less than 20% of what's occurring of the diagnosed cancers in women generally. And when it affects individual patients, unfortunately, we at this time in place, we cannot tell our patients whether their individual type of cancer, is it going to progress or not. We don't have the tools right now, imaging or laboratory tests or specimen testing, nothing to tell one individual patient whether their type of cancer is going to be the bad kind or the slow-growing kind. And that's where some of the information is missed when we're communicating the fact that some cancers might not progress. Yes, we know that in retrospect, but prospectively, we don't have the tools to tell that to our patients. Therefore, it's harder for us to restrict access to treatment or restrict access to diagnosis if we don't have the current tools to give the patient reassurance, is her cancer going to progress or not? The guidelines weigh all these risks, weigh all these benefits, and come up with recommendations. Starting at 40 every year has been the consistent recommendation from major societies that deal with women's health, because this is how we have identified that breast cancer can be minimized. There are morbidity, using less treatments, less aggressive treatments, and giving the patients our best chance. Other recommendations have thought of, well, because of the shortcomings of mammography, let's step back a little bit from screening and give the patients an option of not having such intensive screening plans, which is, I would say, the starting at 45 every other year recommendation, and that's a new recommendation from the American Cancer Society. And I would say the least preferred option is unfortunately what has been released by the USPSTF, where it postpones screening up to 50 years. Why is there the concern about adopting more delayed screening or commencement of screening? Like I said, we don't have any current tools to make safe individual choices for patients, telling them which best tool is available for you, what's the best interval for you, for that specific patient. We don't have that information yet. Delaying screening till 50 years has been looking again through the history of breast cancer for 4 decades, could have cost us 6,500 lives per year. That's from the numbers. These are numbers that the CDC has collected, the cancer surveillance programs have collected over the years. So it is valid data, it is valid numbers. The changing the screening recommendations from big societies and from organizations like the USPSTF will ultimately affect reimbursement. It will take away our choice, individual choice, of either being more aggressive or less aggressive. That's definitely our individual choice, but having these recommendations out there will definitely limit our access. I'll just very briefly touch base on the supplemental screening. What I've talked about, these are average risk women. The higher risk group, the genetically susceptible patients, what Joanne has mentioned, there is more intensive screening guidelines for them, annual, definitely screening, addition of other supplemental tools are in place, but we won't go into that. It's a whole different discussion. So what's on the forefront of research? The medical community definitely identifies the shortcomings of the current screening tools, mammography being the primary one, and we identify that there is not one size fits all. There is what's called precision medicine, trying to tailor the diagnosis, tailor treatment for patients, and taking into account our individuality and our different tissue types. Screening, the digital breast tomosynthesis or 3D mammography is definitely an improvement on the performance on mammography. It does deal with a lot of shortcomings of mammography, some of which I've mentioned. It identifies more cancers. It identifies the cancers that matter, the invasive cancers, not the in situ, and it decreases the false positives. It decreases the chance of patients coming back for benign diseases. So has definitely shown significant improvement. There are big national trials that are open currently that will allow us to vigorously test this new technology. There is also tailored screening decisions. Big trials are also available currently that test the different screening options, when to start screening, how often to start screening, and if this is linked to our tissue types as well. So that's a huge trial. There are precision medicine trials in treatment. Can we tailor treatment? Can we minimize and cut down some of the more aggressive treatments, especially in cases where we know that breast cancer might not be as aggressive, specifically in the ductal carcinoma in situ, the in situ disease. Again, there are a lot of trials, and I just gave you a few of the examples. In summary, I will have to emphasize, and it's unfortunate that this day and age, we're trying to still negotiate or try to prove that screening is the way we should be going. And the earlier prevention, like Phyllis has mentioned, and screening are our ways to fight cancers and fight this battle. But we have to guarantee our right to choose whether we want to be aggressive or less aggressive, again, taking into account our personal preferences. Big national studies are on the way currently, and we'll have data in the next few years that can support one way or the other and better tailored precision medicine. And I would have to say that we all in the medical community identify that decisions regarding healthcare, individual decisions regarding healthcare choices, will have to take into account our preferences, our situations, our risk benefit ratio depending on our beliefs. But again, we have to make sure that all our focused efforts are to identify how to tailor treatment, how to tailor diagnosis, rather than limiting our access. Thank you. I apologize. I went over time.
me now? Hello, hello. So this one is DOA. All right, I'll be using my best Phil Donahue impersonation. Finally, oh, if there's any more cards, raise them up, bring them, we'll bring them up and we'll ask more questions. Our final panelist is Dr. Carla Pugh. Dr. Pugh is a professor of surgery at UW-Madison. She's also the first director of the UW Health's Clinical Simulation Program. Her research involves the use of simulation and advanced engineering technologies to develop new approaches for assessing and defining competency in clinical procedural skills. You got to check it out front if you haven't seen it. It's very cool. Dr. Pugh holds 2 patents on the use of sensor and data acquisition technology to measure and characterize hands-on clinical skills. Currently, over 200 medical and nursing schools are using one of her sensor-enabled training tools for their students and trainees. Her work has received numerous awards from medical and engineering organizations. In fact, in 2011, Dr. Pugh received the Presidential Early Career Award for scientists and engineers from President Barack Obama at the White House. Wow. In 2014, she was invited to give a TED-Med talk on the potential uses of technology to transform how we measure clinical skills. Please welcome Dr. Pugh. Should I turn this off? Okay, wait, hold on. I'm turning off. Sorry, I'm taking the time. Here, I'll go down here and turn it off.
So you can hear me. Thank you so much for your very kind introduction. And I can't help but feel I'm actually standing here to talk to you all about the ugly stepchild of screening, if you will. It has been praised and divorced and said from the self-breast exam you shouldn't do it, or the clinical breast exam we're just unsure of the utility. And I hope in the next 7 minutes I will convince you that we kind of need to look back at this and take a second look. And the first question I will raise is, how can you have breast health awareness without knowing how to recognize something that's going wrong with your own body? Just a question. So now my talk, I would like to thank you all for inviting me here today. This is, I'm really excited. I'm meeting the Thompson family. I'm still really overexcited, and I'd rather be sitting there talking and asking questions about this 20-year passion and this celebration. I'm extremely excited. The other thing I want to do is introduce my research team, do all mine standing: Brett, Cassidy, Anna, Adira. There's no work that gets done by one individual. It's a team effort. And so I am excited to join your team today, and here I go. My goals this morning are to talk a little bit about the sensor technology and the data that we are capturing that is really blowing our minds and making us really excited about a pathway forward in terms of doing accurate, high-quality examinations. And then I'll talk about the implications for physicians and patients. So we are really a geeky research laboratory. We buy materials, actual training technologies from stores, medical device companies, and then we also build some ourselves. If we find one that is almost perfect but is missing one thing, then we go to the hobby shop and buy that thing, or we build it in our laboratory. This one that you see here is a breast model from a company from Japan, and the process that we do is buy sensor technology, and then we embed it into the mannequins or trainers that we buy off the shelf, or we build our own. And then we build a computer interface that shows where someone is touching and with how much pressure. And this is what a breast exam looks like. So each of the different colors represent a different sensor that's placed within the breast anatomy, and you are able to see the amount of pressure that someone is applying over time. We've done this for a number of different technologies or clinical examinations, the pelvic exam, the digital rectal exam, intubation, you name it. We've Collected data over the past 15 years from over 17,000 physicians, as well as we've built over 27 different models. And sensor data, video data, motion tracking data, video data, we are on a mission to understand what it is that the experts do, and then use that information to train those who are in the learning curve. Every time we build a new model, this one is for the female pelvic exam, we take it to a major medical meeting of interest. This is at the American College of Obstetrics and Gynecology meeting 20 years ago, one of the first meetings I went to. This one is a urology meeting, and I can tell you every meeting that we go to, the physicians line up and they want feedback. And that's something that people don't really realize. No one goes to school that long to not know that you can be the best. How do you get feedback? And so they all line up, and even the arrogant ones, of course those don't exist, they say, well, you know, my exam needs to be in this database because I do the best one. So if you're going to teach someone to a standard, and it did confirm I'm the best, right? I'm like, yeah, sure. And the others are, you know, those who've been in practice for 20 years say, how did I do? So doctors want feedback. Back to the breast exam, and this particular simulator that we built, we got a fairly sizable research grant from the National Institutes of Health and did a study. And what we did was look back and say, what is the literature already in terms of the clinical breast exam? How do you perform it? What are the recommendations? And there were 3 recommendations, very specific. This was published in one of the high-impact journals about 12, 13 years ago. And it says that you should use varying levels of pressure, superficial, intermediate, and deep. And it was a qualitative description of what that means. I could say superficial for me, may mean something different for you. And then when you look at the search pattern that's recommended in the textbooks, there are a number of ways that you move your hand to cover the breast. This group recommended the linear strip method. And wow, yeah, I agree with you. The slides are moving. Ooh, okay, I went for the challenge. They recommended the linear strip method. And the other thing is to use the pads of your first 3 fingers. And so we said, can the sensor data give us the answer? Is this what people do? How do they do it? Before we moved along with the study, I wanted to see whether the sensor data could tell the difference between the 2 most common approaches, the linear strip method in terms of how you cover the breast, and the circular. And lo and behold, there's a difference. This is what it looks like when you are doing the linear strip method. And from a mathematical calculation, even visually when you look at it, because the yellow sensor is in the nipple-areolar complex, you pass over it a few times while you're doing the exam, so you see it for a longer period of time than the other when you're doing circular, if you start in the center and go out. So basically with this, the sensor data, with a very simple mathematical calculation in terms of the series in which the sensors appear, I can automatically tell what doctors are doing, what's their preferred technique. Then, and this is the famous warning, they're like, well, okay, great, you can figure that out, but everybody does it so differently, you're still not gonna understand what's happening. And I realized I hit my mic, I won't do that anymore, sorry. So what we did was actually combine the sensor with the video. And what you see here is our setup when we are collecting data from the physicians, and that whenever they touch and they're moving, the video is synced with the sensor map. And I have a picture of that. I'll show you in just a second. Right now, this is the data that you see regarding the amount of force that you use, or palpation pressure. When we took one of the first simulators, we put a fairly sizable mass in the model, and we thought that everyone would get it right. We went to the American Society of Breast Surgeons meeting, and out of the 136 physicians who did an exam on this one model, we usually take 4, 16 of them missed it. And while that's not a big deal, when we are trying to build human beings and trying to make sure that this one everyone gets right, if we cut it in half, then it should decrease, the accuracy should decrease according to the mass. We wanted to get one that was 100%. and 16 missed it. So we were really sort of trying to figure out what happened. So we took those 16 that missed it and then did a match control with a random number of 16 out of the ones who got it right, and we looked at what the difference was. And lo and behold, there it is. Hence the name of our company. So 10 newtons, if you apply less than 10 newtons pressure when you're doing the exam, you are 7 times more likely to miss a lesion. And so those 16 people, most of them did not apply enough pressure to even feel the breast exam. And these are the experts. These are those with 20 years in practice. So we collected more data. Can you play this video, please? What you'll see, this is at the American Academy of Family Practitioners. We also went to the American College of Obstetrics and Gynecology. And you'll see these two physicians are examining the same patient. They have a little bit of difference in their technique. Both of them touch the lesion, but the one on the top doesn't touch it with enough force or pressure to realize there's something there. And when he went to write his note in terms of the findings, he said that the exam was normal. We have thousands of videos like this. After we collected data from over 550 physicians, it wasn't just the surgeons or the family practitioners or OBGYN. Across the board, 15% of physicians don't apply enough pressure to even find a lesion. And when you look at all the research that compares the utility of the clinical breast exam, it's assuming that everyone's doing it right. Just a thought. So going back to search pattern, what we found in terms of the results is that linear strip method is not what most people do. They actually mostly do the circular and some do radial. And I'll move forward. This is the other thing we found. We looked at the videos. Can you play this video, please? We were able to categorize 90% of the people into 3 methods. Some of them are rubbers, either rubbing linear or in a circular. Some of them do this padding or vertical movement. And then there's this piano fingers. There was a term for it, but there were a number of people who do that. And those who do the piano fingers are 4 times less likely to find a lesion. There's a difference between men who get it right and women who get it right. These are our Olympians. I won't go there just because of the time. But there are some differences. Mainly what it means is that we actually need to train women differently than we do men, because they palpate differently and process information differently from their fingertips. So what does this all mean with respect to the clinical breast exam? When we looked at this study that came out in the Journal of Women's Health, 60% of breast cancer survivors reported using a different technique than the mammogram in terms of how their cancer was first identified, that there was a lesion. So 15% of them were in the clinical breast exam, and 45% found their own lesion in the shower or by accident. And this is breast cancer survivors, not from this just general screening of everyone. So just with these numbers, I think that the exam is still important and we need to do some work to rescue it. I'll move on. I think that the data and the technology is becoming less and less expensive, very affordable, easy to use. Doctors want feedback, patients want the best exam. I think that the onus is on us to do the training, to do the testing, and move forward with giving high quality breast exams and combining that with the mammogram and getting the mammogram, a screening mammogram, very different than a diagnostic. And those are 2 different things that should work together. So thank you very much.
Okay, is this on? Is it on? Is it on? Yay, it is. Oh, technology. That's fascinating. Aren't you fascinated by that? Like she lives here. Like that's so cool. So thank you guys, all of you. That was fabulous. And now we are to the question and answer portion of our I almost said evening, our afternoon. Thank you. Oh wait, I have an announcement. The PowerPoint presentations will be on our website after the event. So yay. So all of that information, if you are scribbling down notes to try and get it all, we'll put that on the wwhf.org website, and you'll be able to access that without having to take copious notes. Oh dear, the boss is here. What? Oh, it was off. Well, here, you can have that then. Fabulous. We're back to this. So now we'll ask some questions. Should I start with the one you guys wrote, or should I just start with these? Does anybody care? Nobody cares. So let's just start with you guys' questions, because we got a little bit of a late start, and that's why we're here. So if you look back at breast cancer over the last 10 years, this question is for all of you. What advances or changes do you see as the most exciting? That on the given your speech, I think we know what you'd say. But not necessarily. But what in all of your opinions, what do you see as the most exciting personally from your field? Who wants to start? Did you turn it off?
Can you hear me? No, I didn't.
Okay, they're on it. Go.
Oh. Yeah, I think what's exciting, so I'm not a cancer surgeon. I am a emergency surgeon, and I have a passion for the technology and training and physician excellence. That's my passion. What I think is very exciting, having grown up with an aunt who had breast cancer and a godmother who I saw go through the whole process and subsequently pass away, is efforts like what I see today. I don't think that I've had the level of awareness in terms of women's breast health awareness. Really worldwide advocacy for women to be assertive, partner with other people, take control, and be a part of the passion in terms of learning about themselves and starting an organization and raising money and moving the cause forward. That I think is extremely exciting, because once there's a mass of people, then you can't ignore them. That's what I find exciting.
Anybody else want to jump in on that one?
I would just say our ability to learn about these genetic markers that are related to cancers has enabled us to target cancers differently. Some of you may be familiar with the drug Herceptin, which can be used for women who have a specific type of marker on their breast tumor. We can, and I think this is obviously going to be more and more important in the future, that we can target treatment based on the genetic component of the disease that we didn't know about previously, and that, tailor it, target it. And that's only going to grow and grow. Genetics is going to be more and more important in all of medicine, not just in cancer.
Phyllis?
To me, it's very, very exciting that my experience has now caught up with itself. To make that plain, 12 years ago, integrative care wasn't common. In fact, it wasn't available as a complement to traditional care, but that's what I researched for myself and added and promoted and provided evidence-based advice about to other survivors, and developed a curriculum and a support base based on integrative care, the benefit from it. And so it's very exciting to me to see cancer centers across the nation, including yoga and acupuncture and massage therapy and all of the different things that help, not harm, and ease the traditional therapy and help with peace of mind, body, and soul.
Mine?
I would have to agree with all the panelists, but I'd also add the identifying that not all patients are the same, not all cancers are the same, so more of the individual approach to patients. I think this is a tremendous improvement in health services provided to our patients. Starting from the primary prevention of identifying that there are some patients that might be at increased risk just because of stressors or genetic mutation, through screening? Can we utilize different technology? And it has really guided the evolution of some of the technologic advancement, the surgical and therapeutic options as well. So the more tailored approach, I think, would be the breakthrough, I think, in dealing with cancer.
Exciting. It's exciting times when you think of prevention, right? So here's a question, Phyllis. Who owns the results of genetic testing? Actually, I guess this would be for you, Joanne. Who owns the results of genetic testing, and who can use the results? What permission do you need to use those results? Who owns that DNA banking? Let's talk a little ownership of the DNA testing.
Okay, so two different things.
Okay.
The test results, patients who test get their personal copy of their test results. It is in their medical record. Otherwise, it is only distributed to the persons that patient wants that test result to go to. If they say send it to their primary care provider or only to their oncologist or to whomever, that's the person. We don't send it out to the family. It goes to that particular patient. It's confidential information. It goes under all the HIPAA laws and everything else. The DNA banking issue, you are the owner of that sample unless you designate your partner, your child. You can designate somebody to be the owner of that sample for future usage. So let's say a woman has a sample of DNA banked, it dies, but prior to that, her husband has been designated as the owner of the sample, or her best friend. So you can choose who you want to be the owner of that sample, which is important.
Okay, hopefully we answered that. If that was your question, these guys will be available afterwards if you wanted more details. Hopefully we got that. Here's one. As a survivor, it's sometimes difficult to hear about prevention, wondering if I could have prevented this burden on my family. Without knowing for certain whether my diagnosis could have been prevented, how do you reconcile those questions and just keep on swimming? And you can probably speak to that.
You do have to think about it and just be at peace with how random breast cancer is. I thought I lived to prevent diabetes. I'm the only female in my family who's not diabetic. And so, and an Army vet. So PT, eating right, so on and so forth, maintaining a weight, that was all part of me because I'm, gearing up to defend myself against diabetes. And lo and behold, cancer caught me. So, there's no, we can't say with exactness that what you do to prevent is foolproof. It actually makes you hardier, because then when cancer comes, you are in better health. And that makes a difference when you're going through treatment.
True. Any else want to chime in on that one? All right, we're going to push forward. What is, I love this, what's up with dense breasts? How do we know if we have dense tissue, and how do we decide if mammography is enough? What up with that? Okay.
So dense breasts, our genetic makeup. We're different. There are very few factors that impact our individual breast tissue density. Hormone replacement therapy, for example, can increase breast tissue density, but the majority of times it's just our individual makeup. And when we think of mammograms, again, it comes up from the traditional concept of using mammography to screen for breast cancer, is that I like to think of it as almost looking through a frosted glass. It's harder to see through the breast tissue when it's denser. It's harder to find the smaller cancers. But technologies are sort of improving. Digital breast tomosynthesis is one of the technologies that allow us to look through the breast a little bit better, especially for patients with dense breast tissue. The other thing to think about is recently the breast tissue density has been recognized as an individual risk factor. The thought is there's more of the breast tissue, so there is a slightly larger chance of you getting breast cancer. So patients who have dense breast sort of are thought of in a slightly different, higher tier of risk, not extremely high as patients who have genetic mutation, but they're looked at from what we call moderate risk. And in that situation, in some situations, we might consider other tools in addition to mammography to screen patients with dense breast tissue. You would not know that you would have dense breast tissue unless you get your once you get your first mammogram. Not only by the clinical breast exam. The breast tissue typically feels firmer on breast exam, but you wouldn't really be able to tell until you look at your first mammogram to know.
She's throwing down the gauntlet.
Yes.
We need to be able to tell.
Yes.
So that's a new challenge for you.
Well, no, and as she's talking about that, I think that's a research study, because before I specialized, I did do the breast exam, and you can tell a difference. I mean, at least there is a different feeling, and I always think about women when they're asking about their breast exam, because mostly they only get to feel their own breasts. And physicians, we get to feel hundreds of breasts, and so we walk around with all that information on our fingertips. And so how do I figure out how to share that with you? That, of these 5 models, which one feels like yours? This is what is dense, and then we could do that study, because the women that you see, then I can model a simulator that fills, I could model the tissue such that it fills that way, and we could have a range. So let's do it.
So interesting, cool. Because how do you know? And if you're not getting a mammography till you're 50,
right.
I mean, wouldn't it be nice to have known when you were 20 that you have dense breast tissue? Who knew?
Yeah.
I love it. Oh, you guys were here when this happened. So here's just a side note. Dr. Pugh is a brilliant diagnostician and surgeon. She saved my daughter's life this summer when other doctors wanted to send her home. Thank you for the opportunity to thank her publicly. Wow.
It's an honor and a privilege. It's what I do, both clinically and my research.
Wow, that's phenomenal.
Thank you.
With family history being so critical, how can we best go about collecting that information, and what should we be asking relatives? What type of data should we be writing down? How can we be arming ourselves with our family while they're with us?
Writing down as much as you can possibly learn. With regard to cancer diagnosis, again, age that the person was diagnosed, and if somebody knows what kind of treatment, if they know, sometimes somebody will say it spread. They had cancer and it spread to their lungs, it spread to here or another place, and it's like, well, but where did it start? That's what I'm interested in knowing, the primary source, if possible, to figure that out. We do encourage people to collect medical records, because big hospitals like University Hospital will have a patient's medical records like forever, but community hospitals will only save medical records for maybe 7 years, 10 years. So if those records have been destroyed, they're gone. I mean, you can't recreate them. You just don't know, and it's based on word of mouth. There certainly are some cancers in families that they say, well, it was some kind of female cancer. Okay, there's a bunch of different things that come to mind, but which female? Yeah, which female cancer? Or sometimes we start, was it above the waist or below the waist? Kind of questioning. But there are tools out there. There are computer tools, but you can just sit down and write down your family history or sketch it out in whatever is the way that you would like to sketch it out. Your first degree relatives are your children, your siblings, your parents. And then we look at aunts and uncles and cousins and grandparents. So usually we're taking, or we would like to collect at least a 3-generation pedigree, family history. But again, what we're looking for is the type of cancer, the age of diagnosis, and whatever else somebody can tell us about it. And then if you have questions, call a genetic counselor.
Right, right. This one is for Phyllis. As a new survivor, I've struggled to talk to my daughters about my diagnosis. How have you talked to your daughter and granddaughter about it, and do you have any advice?
It's an important thing to talk to your daughters and your sons, you know, about your breast cancer diagnosis. My daughter, and when I say she's a gift, she actually was, because I was a late mom, okay, and I had been told that I wouldn't have children. So she was actually in high school when I was diagnosed. And so she grew up with me going through treatment, being diagnosed and going through treatment. And being the person that I am, I drew her in according to her comfort level, but still, she knew what the radiation machine looked like. You know, she came and she sat with me with chemo. You know, we would talk about it. It was life. And her life had to adjust according to how I coped. And so there's that dialogue there. That's an entry, you know, way to get a conversation going. But there are good books even today that can start the conversation. And so there are resources to make it an easier conversation, but it's never a good thing to hide your medical history, be it breast cancer or any other you know, disorder. You need to talk about it, because otherwise your family pedigree, that history is erased when you're a mom.
Anybody else have any thoughts on that? Talking to family members about that type of thing?
Well, just as you're saying that, I think, you know, my mom has 14 brothers and sisters. I have 14 aunts and uncles, and one of my mom's younger sisters had breast cancer. And I think about, as a kid growing up, when I learned that Aunt Gladys got breast cancer, we all just we all prayed for her, because she wasn't living in the same state at the time. And then when she came back, it was just really joyous. It was like, she made it, you know, she's still here. And I think as a kid, learning that, I think there's just I mean, for me, there was enough on TV and enough talk about it. And, you know, there's all the fears, but I think it was very helpful to have the conversation and know that my family, even with that many brothers and sisters, that they still talk amongst themselves about everything that's going on. I have another uncle with prostate cancer, and so we're just used to the conversation, and in fact we expect it. Having had that, you know, as a young child, and then now as we're all, and then we check in, we're like, we haven't heard from you in a while, what's going on? So as we've gotten older, then we feel, my sister and I, we have responsibility over our aunts and uncles, and so we call and check in, and we want to be nosy and find out how they're doing and understand what's happening.
You're going to take care of them.
Yes. Can I add?
Absolutely.
I'd like to add, too, your children are your co-survivors. You know, they're your caregivers. You're a unit. Cancer just didn't happen to you. You know, so you have to look at it that way and be able to process through to value how important their perspective is to you and your perspective to them, because they have to carry on. You know, what if it's, you know, they need to be able to look at what's going on and gain strength rather than be weakened by, I don't know what happened to mom.
Right. Age appropriately, obviously, but Yeah.
May I add as well? In talking with children, you know, we know that what you discuss with an 8-year-old is not the same as what you discuss with a 15 or an 18-year-old or a 20-something-year-old. So you tailor the answers to what their questions are. You answer directly and simply. You don't get into this whole discussion about all the chemo drugs that you're getting. That's not what they're asking. So it's listening to what the question is and trying to answer it as straightforward and simply as you can, but again, what's age appropriate, as you say, or not even age, but maturity level. You know, all 18-year-olds are not created equally when it comes to maturity levels. So, you know, there's, and you know your children better than anybody knows your children. You know, so you have to tailor it to them and what your relationship is with them, just to start with.
Yeah, I mean, just like
You're a
anything
mom.
else, when they want to know where babies come from. 3D mammograms. Who should have them? How often? Why are they better?
3D mammogram is just an improvement of the regular mammogram technology. It's one step ahead, and so it applies to anyone who's eligible for a mammogram, starting from 40 every year. 3D mammograms allow us to look through the breast tissue, thin layers through the breast tissue, and so far the studies have shown that it does benefit all types of breast tissue and all type of women. And then more studies are coming out to guide us as to whether some people benefit more, but I think so far what we know is that it benefits everybody.
This is an interesting one. On the internet, like Facebook, there are more and more ads about commercial mutation testing kits that are much cheaper for people without good insurance, but are they accurate? What about that?
They can be accurate. I can tell you sometimes we do want to retest through one of the clinical labs that we use if somebody comes in with a result that we're not so sure about. Each lab is different, and I'd say we're very cautious when it comes to what's called direct-to-consumer marketing. And as I said previously, we kind of think it's really important that you know what test you're doing and what we're going to learn from that test before you do it. You know, testing is, the physical part of testing is you're providing something, whether it's a blood sample or something that will enable you to look at that person's DNA. But the testing process involves thinking, how could this change my medical management? How could this affect my family's, you know, medical management choices? It involves the family. Genetics is never just one person, it's the whole family. Most mutations in cancer risk genes are inherited mutations. They didn't just show up for the first time in that person, so it came from either this side of the family or that side of the family. So again, it's a very big picture. We're thinking about the emotional component of this. How are you going to deal with learning that you have a positive test result, that we just figured out, not why you got breast cancer this summer, but you were born with a genetic message that said your risk to get breast cancer is higher than somebody else at your age. So some people can say, I'm not ready to deal with that part now. Or maybe if there's a brand new diagnosis, there's so many decisions that have to be made. And like, this isn't one I want to deal with right now. Other people will say, yeah, they do want that information and to help with their decisions. And then there's the insurance issues, the how much is it all going to cost. So these direct tests are cheaper, there's no question. They are cheaper than if we go through the process of working with one of the clinical labs, but they should be informed consent tests. I know we get literally signed signatures in order to do genetic testing in the field of cancer. So it's good that somebody's reaching out and trying to learn the information, but sometimes, sometimes the answers aren't as straightforward, and they don't know what it means. Their primary care doctor, if they bring them the piece of paper or 20 pieces of paper, because they looked at this, and this, they don't know how to interpret it. So it's
Well, the answer is only part of the, I mean, what to do, what are you going to do with
Yeah,
it, right?
yes,
Yeah,
in part,
interesting,
yes.
we need help. So what has been your experience regarding patients that resist coming in for routine mammogram screenings? What are the frequency of protests? What are the frequently mentioned protests, or are they fears? And how do you advise a good way to start the conversation with those who resist having a mammogram? How do we help?
I think a lot of times it's the anecdotal experiences. I think people start fearing mammogram from hearing from a friend who has regularly gone in for a mammogram, but they still missed her cancer. And I think it's some of that information when we talk with our friends, with our family, some of that information might not be completely accurate. We might not be hearing the complete story. And these fears, I think, definitely now that we have the internet, you will always, once you Google a mammogram, you'll find, you know, a million results to your search. A lot of them are going to be negative, but I think it's sort of the difficulty in this day and age to try to sift through the information and figure out what's credible and what's not. We're bombarded with information all the time, not necessarily all of it is accurate. I would say speak with your provider. Definitely when we're in clinic and we are recommending a mammogram and a patient refuses, that's completely a patient preference, and it's completely your decision whether you want to get that test or not. But understand what you are giving up and willingly do it. That's completely your choice. But get the appropriate information. Know the facts, and that's sort of what I was trying to do with today's talk, is know what the true information available is, and make your decision, make an informed decision, not just based on, you know, the Times or
Right.
Google search or.
Right.
When, you know, being deeply involved in community work, it's not my choice, but it's a necessity that I be real familiar with social media. Okay, and so
I feel the same way.
all right, and so there are some things that happen on social media that ignite women and put them into action by sharing experiences on Facebook and Instagram and the rest. But this week, I think it started this week, the hashtag #MeToo. Okay, so you all heard of that. And just like that, and the women who stepped up and told their stories, and a few men, and you know, empowered each other, it's also happening this month with mammography. Women are taking pictures of their mammograms and putting them on Facebook and saying, it didn't hurt like I thought it would. You know, come on, Rosalind, it's your turn. You know, I mean, you know, so that this is happening in real time, that this is useful, because there is a lot of fear. And so, like domestic violence, people were silent, and being the one who didn't get a mammogram, people have been silent. But, you know, they're being brave enough to tackle it, and the synergy, you know, in Facebook groups and the messaging has been just delightful, you know, to see that there's some energy around getting mammograms.
Yeah, no, I group that under communities of learning, and I think that we still have we can't do enough to find all the various ways to reach out to men and women, to empower them to get an accountability partner, to have that conversation outside of their family. The first time that we took our simulator to a women's wellness meeting, one of the large annual meetings, we had hundreds of women come and visit, and just the conversations that took place blew us away, because we were used to using the technology with physicians. So the very first time that we used it with women, I was surprised at the number of them that opened up and said, yeah, you know, my brother had prostate cancer, I just don't want to know. And it hurts when you hear that as a physician in healthcare, but then you know that there's more communities that need to be developed. That person who said that to me, all of the people who said they need a partnership outside of their home, they need to know that there are survivors, they need to know, this is what my cancer felt like, this is what it was, this was my mammogram, this is the size of my lump, and I'm standing here talking to you. There's still a whole lot of work to be done.
It seems to me too, and if you're a loved one of someone trying to encourage them, that you can encourage them that do it for me. I don't want you to leave me, right? I mean, if you go get tested, I selfishly want you to know because I want to keep you here as long as I possibly can, right? If it's your mother. My grandmother wouldn't register to vote because she was afraid she'd get called for jury duty. So, like, it's that kind of reasoning, like, no, go find out, do it for me, right? Doesn't that make sense?
Can I just add, and speaking to our first question of the day, how can you reconcile with hearing about prevention now that you are a survivor? I think just going through the experience, and usually when you've gone through the diagnosis and treatment of cancer, you've really lived that world. You know that knowledge by heart. I think being a survivor is great. A lot of advocacy groups came out from survivors. You have that knowledge, and it's much easier for other people to hear it from people who've gone through the experience. I think it should be empowering. Life throws a lot of challenges at us, and just think of it that you've gone through it, you've dealt with it, you've survived. This has made you more resilient, and take that experience, take it out to your friends, to your church groups, to your family members. Speak out about your experience. Help people reach to the appropriate resources now that you've gone through the process. You know what is credible information, what are the credible resources that people can get or reach out to learn more information.
And then we're about to wrap up, but there's several questions on risk factors. Alcohol consumption, does it impact other cancers? What about those Milwaukee zip codes? Why are they higher? And then also the rural areas. Could it be like chemical spraying on farms, that kind of thing? Can you talk just a little more about the risk factors?
Environmental risk factors, like what is it about the 7 zip code area in Milwaukee? What is it about rural areas? I think it's Washington County. I'd have to look to be sure. But just what is it that all of the women who are more at risk, what is it that they have in common? That hasn't been discovered yet. The sister study, that's been a long-term study for I don't know how many years, where the one who was diagnosed with breast cancer, sisters were included, hair clippings, fingernail, dust from their home, this, that, and the other, and all of this information is trying to come up with what is the common denominator. And the one that I can think of, and if I'm remembering it correctly, in North Carolina, there was a study where I believe it was for black women with triple negative, and they did find something in the soil. I mean, so what will it be for this day and age, and for it to be a pattern, not just in Wisconsin, but in other states, that there are pockets that women and men who are at higher risk, that the research needs to be done so that it can be made plain, how we can better protect ourselves.
And then you want to just touch on the alcohol consumption question?
The alcohol consumption question. Well, evidence has shown, and still, with long-term research and being able to put it in the category as tested and true, it is believed that more than 1 drink a day increases the risk of recurrence and of your primary cancer, of a primary cancer. What the mechanism is, I don't know, but there has been a strong correlation drawn between alcohol and breast cancer.
And does that spread to other cancers, or does that affect other cancers as well? Do you know?
I believe colorectal and others.
It would stand to reason, I would say.
I believe colorectal and others. And just what it is about alcohol, I don't know. But there is strong evidence that more than one drink, and if it's a beer or if it's a scotch, it's not that hard fast, but just alcohol, period.
Doesn't help you lose weight either. Just saying. So we have wrapped up our questions. I know there were a few. I'm so sorry if we didn't get to yours. There's a few here we didn't get to. And if they are on your heart and you want to ask, please make your way up here afterwards, because I'm sure these women would take a moment to speak with you about that. So once again, thank you so much. It is incredible that you've shared all this information with us today, and it's just an honor to be in the same room with a brain trust like this. So thank you all very much for everything.
Thank you.
Amazing. And thanks to all of you for coming out today bright and early. Thanks to our sponsors and our partners, and of course all of the attendees. We want to encourage you to keep the conversation going. I like the way this wrapped up, because that's kind of how we wound up. Talk to your friends and family about what you learned today and your mammogram. Share the information and the resources that we found here today. Our event is live streamed, and so you'll be able to see it again on the website, www.hf.org, on their YouTube channel. I'm sure there'll be links all over the place. You'll be able to find it once the spinning wheel finishes its work. Thanks for your attention and for coming out today. If you haven't had a chance to visit the exhibit booths out front, they're incredible. I encourage you to explore the resources related to breast cancer and breast health there. They'll be open for about half an hour. And thank you very much for coming out today. Hope to see you next year. Yay! And with that, we're done.